السلام عليكم دكتور محمد.
عليكم السلام دكتورة فاطمة. You can start the session. Okay, you are in time.
بس هذا
Yes.
الفيديو.
Sorry.
الفيديو by the host.
Okay, it's already working, Dr. Fatma. You can go ahead, just introduce the first presenter, and everything is working. They are with you.
Okay.
Okay.
Assalamu alaikum, everyone. Good evening. My pleasure to be with you today, and I like to thank everyone who participated with us in our Al-Qasmi International meeting. And special thanks to Dr. Muhammad Al-Umari, who is head of the scientific, and he arranged all these events. Thank you, Dr. Muhammad, for your effort. And also my pleasure to be among the young ophthalmologists. And I want now to ask Dr. Fairuz.
Assalamu alaikum.
Yes, Doctora.
Okay, I start to share my screen. Okay.
Yeah, please.
Okay. Okay. Is my screen shared now?
Yes.
Okay, so I start. I am Fairuz Abu-Azaim, lecturer of ophthalmology at Al Shiraini Cairo University. I will discuss the topic when the lens subluxation is associated with traumatic hypotony. What can we do? My first case is a 10-year-old child that had left blunt trauma, and he presented with visual acuity of counting fingers 50 centimeters, and he had traumatic cataract with 5 clock hours of subluxation, and the IOP was 2 millimeter mercury, and he had vitreous in the anterior chamber with fundus showing picture of hypotony, disc edema, and choroidal detachment. The patient was given topical and systemic steroids as well as subtenon steroid injection. However, the IOP remained very low, 3 millimeter mercury. Intravitreal sec gas injection was tried, but also failed. UBM was ordered for the child, and it showed the presence of 3 clock hours of ciliochoroidal detachment. And it was strange that the area of the ciliochoroidal detachment was opposite to the area of lens subluxation. At that time, I reviewed the literature and I found some case reports of trying to apply cryotherapy to the ciliochoroidal detachment to make some sort of cryopexy. So cryotherapy was applied in a double freeze thaw over the area of the ciliochoroidal detachment, together with intravitreal non-expansile gas injection just to form the globe, opposing the detached ciliary body to its original place after performing some sort of inflammation using the cryotherapy, hoping that it got attached to its original place. 1 month later, the patient has complete resolution of the choroidal detachment and the ciliary body detachment, except in less than 1 clock hours, and the IOP was 16 millimeter mercury, surprisingly. And the patient was scheduled for cataract extraction. And this video shows the operation. The idea was to fixate the capsular bag to the sclera and doing irrigation aspiration and IOL implantation. So I started to do variotomy at the area of subluxation, and then I did a groove, scleral groove, to embed the 10-0 Proliene sutures. I did dry anterior vitrectomy, preventing more vitreous prolapse in the anterior chamber, and then I did the anterior capsulorhexis. It was not an easy job because the child was 10 years old, the capsule was extremely elastic, the vitreous was adherent because he had this problem about 4 months ago, so the vitreous was attached to the anterior capsule, but I was able to perform it successfully, and I was trying hardly to centralize it, to be able to centralize the IOL later on. Then I did support of the capsular bag. I didn't have capsule hooks at the time, so I used iris hooks to pull the capsular bag and stabilize it during irrigation aspiration. And then I did hydrodissection gently. And then irrigation aspiration. He was a 10 years old child, so irrigation aspiration was not difficult, it was easy. Using the bimanual. Then irrigation aspiration is finished. And then I tied a 10-0 proline suture over the eyelet of a Sayuni ring. Then I started to insert the Sayuni ring inside the capsular bag, keeping the eyelet anterior to the anterior capsular axis to pull it to the sclera. And then I started needle docking of the 10-0 proline sutures. Keeping in mind to exit inside the scleral groove, which was created at the beginning of the surgery. And then I tied it inside the groove, keeping the knot embedded inside the groove. And then I implanted 3 pieces IL to add more support to the capsular bag. I inserted it first in the anterior chamber, and then gentle manipulation using micro forceps. I pulled it to insert it inside the capsular bag to add more support to the capsular bag. To leave a perfectly centralized intraocular lens. And then irrigation aspiration and closure of the conjunctiva. After 1 month, the patient had best corrected visual acuity of 0.8. His intraocular pressure was about 17 millimeter mercury. He had only 1.5 diopters of astigmatism with perfectly centralized IOL and flat retina to leave a happy patient and a happy doctor. The other case, the same scenario, but in older patient. He's 40 years old patient, had left bound trauma with hypotony, visual acuity 165 clock hours of subluxation with vitreous in the anterior chamber. After performing cryotherapy over the area of the cilichoroidal detachment and the IOP was controlled, the patient was scheduled for flange technique for cataract extraction and fixation of the bag. The subluxation here was superinasal, so I set on the temporal side to be away from the area of subluxation and from the prolapsed vitreous. Then after anterior capsular axis, I did viscodissection of the lens matter. Then fixation of the bag. I was prepared at time with my capsular hooks. So I centralized the bag and supported it using the capsular hooks. And then I did phacoemulsification. He was 40 years old patient, so he had the nucleus, so I have to use the phaco probe. And after finishing lens removal, I prepared my Sayuni ring again, type 1L Sayuni ring. And at that time, I used the 5-0 proline suture, creating a knob and then passing it inside the fixation eyelet like in the video. And then I inserted the Sayuni ring, taking in mind that the first part touching the capsular bag should touch the subluxated part, because otherwise, if it is inserted the other way, it would induce subluxation. So we have to choose the type of the Sayuni ring we insert prior to our surgery. Then keeping the eyelet at the area of the maximum subluxation, which is the superinasal, with the aid of a micro forceps, and a Sensky hook. Then I used an insulin needle, forming a tunnel 2 millimeters from the limbus, and then passing it inside the globe to dock the suture inside the needle, and then externalizing it inside to the sclera to perform another knob and embedding it inside the tunnel, like we use in a Yamani technique in cases of scleral fixation of IOLs. After docking it inside the insulin needle, I externalize it to the scleral surface And notes here on pulling the suture, the bag got centralized, and again, I inserted 3 pieces IOL to add more support to the capsule bag, implanting it first in the anterior chamber and then in a controlled way using a forceps inside the capsule bag. To leave a perfectly centralized IOL. And then I cut the remnant of the suture and by the cautery created a knob and embed it inside the tunnel. Then irrigation, aspiration, and closure of the wound. This patient had about 2 weeks now and he's doing very well. So my take-home messages is that you have to put your plan before your surgery and be prepared with all your equipment to try to provide the best for your patient, and please don't let these eyes with hypotony to pass into physis bulbi. And thank you for your attention.
Thank you, Dr. Fairouz, for this very valuable presentation. And that now, Dr. Hanan Sadiq,
please. Hello, can you hear me?
Yeah, Hanan.
Hi. I'm here.
Yes, Hanan, go ahead.
Okay, hello, hi everyone. My name is Hanan Sadiq Al-Hakimi, first year ophthalmology resident from Yemen. It's really a pleasure for me to be part of this great conference, and I'm really grateful for this great opportunity. Can I share my screen, please?
Yes, Hanan, please go ahead.
Okay, can you see my screen?
No, still nothing there.
Can you see it?
Yeah, it's okay now.
Okay, I'll start. Okay, today I'll present to you a very interesting case of a female that was presented to us in Al Jamhuri Hospital Ophthalmology Department clinics under the supervision of Dr. Abdullah Al-Baham. Okay. Our case is about 35-year-old female patient presented complaining of sudden, pale, less progressive loss of vision in the left eye for 3 weeks. The patient can recall the exact date of symptom beginning, which was Ramadan 15th. So we started to think what may cause unilateral, sudden, pale, less progressive loss of vision, which may include central or branch retinal artery occlusion, non-arteritic ischemic optic neuropathy, retinal detachment, central branch vein occlusion, vitreous hemorrhage, optic neuritis, brain tumor, and lastly, the diagnosis of exclusion, which is malingering. So we'll proceed with the first step, which is history, in order to narrow down our differential diagnosis. As we said, the chief complaint was sudden, pale, less progressive loss of vision in the left eye for 3 weeks with no other complaint. There was no history of any chronic diseases, including hypertension, diabetes, cardiac diseases, hyperlipidemia. No history of any medication use, no history of recent or old trauma, no history of ocular surgeries or other surgeries, no history of irradiations, and lastly, no history of any similar family incidents. So unfortunately, the history was clueless in helping us narrow down our differential diagnosis. We'll proceed into the next step, which is examination. Patient examination, the visual acuity in the right eye was 6/9, and in the left eye, it was counting finger less than 20 centimeter. It was bilateral, normal ocular muscle movement, no proptosis, normal IOP bilaterally. Slit lamp examination showed normal lids bilateral with no abnormalities, normal interior segment, including clear conjunctiva with no congestion, clear cornea, normal lens, normal iris, normal AC depth, no rapid and regular reactive pupil. We tried to do a visual field of the left eye by confrontation test. However, due to the severe decrease in the visual acuity, that wasn't possible. So we dilate the patient pupil in order to examine the fundus. Fundus examination showed bilateral flat fundus with bilateral optic disc, normal, no cupping, no swelling, normal macula bilaterally with normal foveal reflex. So again, the examination was clueless in helping us narrow down our differential diagnosis. And for a moment, we thought maybe the patient is malingering. So we, as a last decision, as a last choice, We sent her to do a brain MRI that included the orbit, optic tract, optic chiasm, and cavernous sinus. And sadly, as you can see here, that is the patient MRI images and report. It showed a mass that is extraaxial, measuring 5.8 multiple 5.4 multiple 5 centimeter in diameter, showing vivid enhancement with dural tail, encroaching the orbital apex, engulfing the internal carotid artery, with crossing the midline, compressing the left ventricle with midline shift effect, with most likely diagnosis of left sphenoidal bridge meningioma. So our final decision was to refer the patient to a specialist, which is a neurosurgeon, to decide what's the best way to handle the tumor. In this particular case, the decision was to do a debulking surgery because total excision wasn't possible due to the engulfing and encircling of the internal carotid artery. Overview of meningioma. Meningioma is a tumor that arises from the meninges, which is the membrane that cover the brain and spinal cord. Their location may cause severe morbidities and mortalities. Epidemiology of meningioma, it is considered the most common CNS tumor, accounting for 1/3 of all primary tumors. Its incidence rate varies according to many things, including the race. It is more common in Black American. Age. It is increased progressively with age, with median age of presentation is 65 years. It is very rare in children and usually associated with neurofibromatosis. Lastly, gender. It is more common in women with female to male ratio of 2 or 3 to 1. And the female predominance is highest in the middle age, as we can see in our case. Risk factor of meningioma, according to many studies that was done, it include ionizing radiation, genetic predisposition, hormonal factors, low estrogen and progesterone, others such as breast cancer, head trauma, and obesity. Pathology of meningioma. WHO classified meningioma according to the morphological criteria into 3 grades. WHO grade 1, which is benign meningioma, WHO grade 2, which is specific subtype, including the clear and the choroid meningioma. Lastly, WHO grade 3, which is malignant meningioma. Now, this WHO classification is important because it correlates with the outcome and it has a major impact in treatment plan decision. Patients with WHO grade 2 or 3 are more likely to have invasive disease, local recurrence after initial treatment, and overall shorter survival rate comparing with the WHO patient grade 1. Meningioma location. Meningioma can arise anywhere from the meninges in the dura. As you can see, this table showing the different location of meningioma with the percentage of prevalence, with the parasagittal being the highest and the multiple being the lowest. Now, for us as ophthalmologists, the most common 2 sites we see is number 1, sphenoidal bridge meningioma, which is further subdivided into the lateral, which is petronial, middle, which is alar, and lastly medial, which is clinoidal. The clinoidal meningioma can encircle the internal carotid artery, affect the optic nerve and other cranial nerve. The second side is optic nerve sheath meningioma, which is uncommon benign tumor arises from the meninges covering the optic nerve, usually in the intraorbital or in the intracanicular part. It should be differentiated from a secondary intracranial meningioma extending into the optic nerve. It is usually considered the second most common of optic nerve tumors, with approximately 1 to 2% of all meningiomas. Clinical presentation of meningioma, it depends on the location of the tumor and the time course over which the tumor developed. Like usually they are slow growing tumors, asymptomatic, and instantly discovered during autopsies or neuroimaging. Meningioma can produce its symptom by different mechanisms, including irritation, compersion, and stereotypic symptoms, which is characteristic focal deficit caused by a tumor in a specific location. For example, visual change if the meningioma affects the optic pathway, which can be presented either by progressive unilateral visual loss, as in our case, or optic atrophy in one eye with bubble edema in the other eye, the so known as Foster-Kennedy syndrome, or mild weakness of the extraocular muscle, and lastly, visual field effects. Other non-ophthalmologic symptoms, which is loss of hearing or smell, mental status changes, extremity weakness, and obstructive hydrocephalus. Neuroimaging of meningioma. Usually meningioma has characteristic features in both CTs and MRI. They are usually extraaxial dural masses showing iso-intense to hypointense signal in T1 weighted and iso-intense to hyperintense signal in T2 weighted images. They are showing characteristic feature of marginal dural thickening that tapers periphery, the so known as the tail sign. Now, diagnosing whether meningioma is atypical, benign, or malignant, depending purely on the neuroimaging, is very difficult and need histological confirmation. Management of meningioma, it differs according many factors, including the patient age, symptoms, comorbidities, location of the tumor, size of the tumor, and facilities available. It may be either observation, surgeries, which has so many different approaches, or radiation. Take a home message. Be systemic in every patient you see. Take a full history and detailed examinations. Meningioma can be presented by different presentations and symptoms. Always keep brain tumors, including meningioma, in your differential diagnosis. Choose the best investigation that would help you to reach the diagnosis. Never say malingering to a patient before you exclude all other important differential diagnoses. Those are my references. This is my email if you have any questions. Thank you very much for your attention.
Thank you, Hanan. Very nice, interesting case, and very nice review of the case also. Thank you very much. Now
Thank
I
you
like
very
to.
much.
Yeah,
I will
Nice-
stop sharing my screen.
Nice
Yeah,
presentation.
nice presentation. Really good luck. And I like to invite now Dr. Ubaid Rahman. Ubaid, you are ready?
Am I audible?
Yes. Go ahead,
Yes.
please.
Okay, Assalamu alaikum and good evening to everyone present here.
Walaikum assalam.
Is my screen visible to everyone?
Yes, but not full screen.
No. Now full screen?
Yeah,
Yes.
yes. Go ahead, please.
Just 1 minute, please. Yeah, so I am Dr. Ubaidur Rahman and I'm going to talk today on intraosseous venous malformation of the orbit. But before I start, I want to express my sincere gratitude to Dr. Muhammad Al-Amri and all the organizers for giving me this opportunity. So I'm an adjunct consultant currently at Department of Oculoplasty and Ocular Oncology at Dr. Shroff Charity Eye Hospital in New Delhi. I have no financial disclosures to make. So I'm going to talk about a series of patients who presented to us with different presentations. So the first one, she is a 40-year-old female and who presented to us with fullness of the malar or the cheek area. So if you see on the left side, there's a fullness here which is not present on the right side, which is flat totally. So on this side, another thing you can see, there's a little dystopia. The globe is moving up. So on clinical examination, there was a hard mass palpable on the lateral part of the inferior orbital rim. Otherwise, her ophthalmic examination was within normal limits and her vision was 6/6. So a CT scan was ordered for this patient, and on the CT scan, a round bony mass was seen, as can be seen here. And this mass had certain internal trabeculations in a honeycombing pattern. So we were in a dilemma. We thought whether it could be an osteoma or maybe an orbital intraosseous venous malformation. So a digital subtraction angiography was also ordered for this patient, and it showed feeder vessels arising from the branches of external carotid artery. So this was a vascular mass. So we went ahead with exploration of this mass, and you can see there's a transconjunctival approach which has been converted into a swinging lid flap, and this mass was isolated, looking very vascular, bluish, and a safe margin of normal bone was marked all around the mass. And this is a piezoelectric fitter being used to excise the mass. So this was the defect left behind by the mass. After achieving hemostasis, a titanium plate was molded in this particular configuration and secured with titanium screws. And this particular wound was closed. So now we move on to the histopathology of the mass. On gross examination, in the first image, you can see there's a round mass, bluish discoloration, blue-red in color. And on cutting the mass in the image below it, we can see there are venous channels, there are blood channels there, and there's a honeycombing pattern seen. On H&E staining, we can see here these are endothelium lined spaces, single line of endothelium. And within these cavities, there are red blood cells, and there are fibrous septa which are dividing these channels. And here you can see this is the bony structure. So a diagnosis of intraosseous venous malformation was made, and this is the patient at 3-year follow-up. And you can see, as compared to her first image, the malar prominence on the left side is gone. Both sides are comparable now. So coming to the second patient, this was a 21-year-old female who presented with proptosis and dystopia of her left eye, which can be seen, which she had since childhood, and it was gradually progressive. There was no pain to the patient. The visual acuity was 6/6. Ophthalmic examination was within normal limits. So again, CT scan was ordered for this patient because a hard mass was palpable along the superior and the lateral orbital rim. And in the CT scan images, you can see there's a mass arising from the bone. This is a bony mass which is pushing the globe outwards, and it has several channels within it. There's a trabeculated pattern. Digital subtraction angiography revealed feeder vessels from branches of external carotid artery. So again, we took up this patient for debulking because she was a young female, cosmetically concerned, and here orbitotomy is being performed, and debulking of the mass was done. Since you can see in the CT scan, this mass is involving several bones, the frontal bone, zygomatic bone, the greater wing of the sphenoid, and it was again a vascular mass. And just to inform you, embolization of the feeder vessels was performed in both the cases, in the first case also, this case also, and after that, the surgery was performed. So maximum debulking was done as much as possible for this patient. On histopathology, again, we see this is the bone structure, and within the bone structure, there's an endothelial line cavity which contains lots of red blood cells. So again, a diagnosis of intraosseous venous malformation was made. And now this is the patient at 3-month follow-up, and you can see there's a reduction of proptosis. So when she initially presented, she had a proptosis of 12 millimeters, and currently she has a proptosis of 5 millimeters, but the patient is cosmetically satisfied. And we can see below, these are the post-operative CT scans compared to the pre-operative CT scan. So we can see the mass, a lot of portion of the mass is gone now because debulking has been performed for this patient, and proptosis has also reduced. So this was our third patient, a 28-year-old female. We can see there's a proptosis of the right eye here. She had history of 1 year gradually progressive proptosis. There was intermittent pain, but no other complaints. Vision was 6/6 again. So a CT scan was performed for this patient because we could not delineate the margins of the mass. And on the CT scan, we see this appearance. And again, several bones are involved here. The frontal bone, again, the zygomatic, and the greater wing of the sphenoid was involved in this particular patient. So we made a probable diagnosis of a polyostetic fibrous dysplasia. And in this patient, on DSA, there are feeders from ophthalmic artery. Now, in this particular case, we could not do embolization because embolizing the feeder artery from the ophthalmic artery carried a risk of vision loss. And since vision was 6/6, this was a young patient, we performed an incision biopsy just for diagnosis. And on incision biopsy, you can see this is the bony structure. Within it, these are endothelial lined cavities containing lots of red blood cells and a lot of fibrous septa in between. So we were surprised on the appearance of this mass on CT scan and histopathology not correlating. So the final diagnosis based on histopathology was intraosseous venous malformation. For all these patients, immunohistochemistry was also performed, and immunohistochemistry was positive for CD34. That confirms endothelial origin. So all this brown structure you see, this is positive for CD34. That means the origin was endothelium. And it was Ki67 negative. So Ki67 is a proliferation marker. So negative Ki67 means that there was no endothelial cell proliferation or proliferation of the cells. So in our case series, we could find 6 patients with average age of 30 years. The duration of symptoms was from 6 months to 10 years. And there was equal distribution between the left side and the right side. The most common symptom in the patients was proptosis. And we followed these patients right from 6 months to up to 4 years. The most common bone involved in these cases was frontal bone and zygomatic bone in 4 cases each. So there was a female predisposition. Out of 6 patients, only 1 was male and 6 were females. In 3 of the patients, complete excision was performed after embolization. In 2 patients, we could not excise, so incision biopsy was done for diagnosis. And in 1 patient, who was case number 2, partial excision was performed for debulking. So this is the data of all our 6 cases. I've already discussed 3 cases. I cannot discuss all 6 cases because of paucity of time. But case number 4, I'll just brief you. In short, was a 20-year-old female, again with proptosis and a superiorly displaced globe. Maxilla and zygomatic bones were involved, and total excision with reconstruction was done. In another case, which was a 23-year-old male, he had an expansile lytic mass involving the frontal and ethmoid bones. Again, in this patient, there was embolization done, followed by complete excision and reconstruction. And the last case was a 48-year-old female who had an expansile lesion showing ground glass appearance. This patient refused surgery, so an incision biopsy was done for her. In all of these patients, we maintained follow-up from 1 year to 4 years. There has been no recurrence in any of the patients and no increase in proptosis in any of the patients. So now coming to the discussion, venous malformation is known by a very famous misnomer, that is cavernous hemangioma. But this is a wrong term. So amongst tumor and tumor-like conditions, venous malformation forms the most common soft tissue pathology of the orbit. But when we talk about bones, this pathology becomes very rare. It constitutes for less than 1% of all bony tumors. And out of these cases also, more than half of the cases are seen either in the vertebra or in the calvarium of the skull. So venous malformation of the orbital bones is very rare. The first case was described by Raubotham in 1942. And since then, 80 years have passed, but only 72 cases have been described. There's a female preponderance noted in these cases and a peak in the 5th decade of life. So typically, yes, sir.
Doctor. 1 minute, Doctor.
Yeah.
Continue. Still 1 minute for your lectures.
Okay, so typically these are slow, benign lesions, and symptoms can vary from proptosis to swelling to diplopia and even epiphora in some of the patients, depending on the site. So these arise from the intradiploic veins within the bones, and after any trauma or any angiogenic accident, these masses start growing in size. They gain feeder vessels from surrounding vessels, and then these masses grow in size, leading to bony enlargement. So a honeycombing pattern is the classic appearance seen on CT scan. Other appearance can either be sunburst that shows radiating trabeculae, a radiolucent appearance, or lytic lesion. So it has several differentials such as fibrous dysplasia, meningioma, bony osteoma, or aneurysmal bone cyst. But the 2 closest differential diagnosis, one is fibrous dysplasia and another one is meningioma. So fibrous dysplasia typically has a ground glass appearance, and it is very difficult to differentiate clinically from an intraosseous venous malformation. But an MRI can show signal voids and strong contrast enhancement, indicating towards a vascular lesion. But definite confirmation can only be done on histopathology. Similarly, meningioma is a very close differential. But in meningioma, the striations are vertically aligned, unlike the venous malformation, in which there's a sunburst pattern. Also, meningioma shows a reactive sclerosis and erosion of the inner bone table. So these are highly vascular lesions with several feeder vessels, and preoperative embolization reduces the risk of intraoperative bleeding. After embolization, vascularity decreases, but surgery should be done within 48 hours. Otherwise, the vessels can again grow into the mass. So treatment of choice remains complete excision with a normal bone margin and reconstruction of the defect. But there are other options also depending on the patient, such as partial excision observation in certain patients. Certain authors have also described sclerosing injections and radiotherapy. Then there are certain upcoming modalities such as ultrasonic knife aspirator, which can excise the mass with much safety. On histopathology, we can see dilated endothelium line vascular spaces, as was seen in our patients. And according to the International Study for Vascular Anomalies 2018, we should call these lesions as hamartoma instead of a hemangioma, because there is no endothelial proliferation in these lesions. So to summarize, this lesion is very rare, but clinicians have to be aware of this lesion. Presentation can depend on the site, and radiological appearance can be suggestive of a venous malformation. For management, there are several factors that have to be kept in mind. And since this is a highly vascular lesion, pre-operative embolization is recommended. Otherwise, there can be intraoperative bleeding. So these are my references. And at the end of the talk, I want to acknowledge my mentor, Dr. Kasturi Bhattacharjee, who was my mentor during fellowship. And I want to thank you all for your kind attention.
Thank you, Dr. Ubaid Rahman, for very nice presentation. And I would like now to invite Dr. Reem Al-Faqih to go ahead for her presentation.
Thank you.
Okay, good evening.
Yes, Dr. Reem.
Share your screen, yes.
Full screen, please.
Is my screen apparent to you?
Yes.
Show him, please, full screen.
Yes.
Yes. Yes, go ahead.
Okay. Good evening, everyone. I would like to express how happy I am to present in front of you and to have that good chance to take you in an interesting 10-minute journey, as I hope in an interesting case that we have. My name is Reem Al-Faqih. I'm a general ophthalmologist from Yemen. Our journey will start with meeting our patient at first, then we'll take a deeper look at the patient's case, our clinical approach and management, and then we'll discuss the case in general briefly. Before everything, this is a declaration of the patient's consent that we have all appropriate consent forms to present his case today. First, let's meet our patient, the hero in our story. This is our patient, a 60-year-old male patient who presented to the clinic complaining of protrusion of the right eye in an insidious onset for the last 1 month, progressive in course, and it was associated with no pain and no visual complications that he's complaining of. His eye history, to that eye, he has no relevant history, no major complaint before, no surgery or trauma. As for the other eye, the left eye has decreased vision over the last 20 years. He had a cataract surgery at that time. His general medical and surgical condition is good. He has no present chronic disease as diabetes or hypertension, no relevant surgical or major health issues, and no allergies to food or drugs that he can remember. By his examination, his general eye examination showed a visual acuity of 20/30 in the right eye, corrected to 20/20, hand movement in the left eye that was not improved by correction, and an IOP normal in both eyes. Extraocular examination showed normal movement and no limitation in any ocular movement. As for the mass examination, in the right orbit, as we can see, it's a palpable mass, firm in consistency. It was not pulsatile, and there was no ocular bruit, no tenderness, and the skin overlying it, as we can see, showed no significant mark. The regional lymph nodes were free too. Our proptosis examination showed an axial proptosis in the right eye of 22 millimeters and normal in the left eye. Slit lamp examination also showed normal structures except for mild redness of the conjunctiva in the right eye with early nuclear sclerosis. In the left eye, the pupil was irregular, sluggish in reaction, and he was pseudophakic. His dilated fundus exam showed no abnormality in the right eye, but optic disc pallor in the left eye. So our clinical workup was first to send him to radiology. We sent him for magnetic resonance. As you can see here in the images, the eye is compressed and pushed forward by an infiltrating mass that's occupying only the right orbit. As you can see here, it's engulfing the muscular cone and extraocular muscles and the optic nerve inside. This is the size of the mass as the report mentions, 4 by 3 by 7 by 2. So our list of differentials was hemangioma, orbital lymphoma, optic nerve meningioma or glioma, orbital lymphangioma, or metastasis from any other site. Next step was the surgical workup. The patient was scheduled for elective planned excision. Our aim was mass exploration and mechanical decompression and obtaining an incisional biopsy. This is the biopsy that we have taken. It's about 3 by 2 centimeters, firm in consistency, fibrous and relatively avascular, but there was no distinct plane between it and the orbital fat. As lymphoma was one of our main differentials in the list, the specimen was sent for histopathology in saline. No formalin was added. This is our patient, day 1 post-op. Those are the histopathology slides. As you can see, it reveals sheets of undifferentiated cells with scanty cytoplasm and multinucleated. Next step was immune histochemistry, which shows diffuse positivity for CD20 and negative CD30. So the diagnosis was a high-grade large B-cell non-Hodgkin's lymphoma of germinal center type. Our management plan was discussed, of course, with the oncologist. We both worked to take the patient to the safe side. The process of management first was to do the staging to make sure that the lymphoma is only confined to the orbit and if there is any systemic involvement. The second is to choose the best treatment method that we can do for this patient. And the last is to treat and follow up the patient. So as to have the correct staging, the patient had full blood work, neck, chest, and abdominal ultrasound and CT scans, liver and kidney function tests. All of them revealed no abnormalities. So no systemic involvement was found. And second, we had to discuss with the oncologist the treatment options. The first option was surgical excision, but as we have seen before in the MRI images, the location of that tumor would prevent us from completely excising it without altering the function of the eye. Other treatment options were chemotherapy, radiotherapy, and immunotherapy, which we don't have in Yemen, and still under research as the relapse rate is very high. As for radiotherapy, many authorities say that it's the most preferred treatment modality, but for this patient, he is a single-eyed patient. We could not risk the radio complications that might be vision debilitating as retinopathy. Chemotherapy may not be the best choice for most lymphoma cases that are confined to the orbit, but in our case, which is a high-grade diffuse large B-cell lymphoma, it was the best choice that we have. So with the oncologist, we decided that the regimen for treatment would be the R-CHOP regimen of combined chemotherapy. The patient started receiving vincristine of 2 milligrams and doxycycline of 16 milligrams for 6 cycles in Al Jamhouri Oncology Center under the supervision of the oncologist. After 6 months of chemotherapy and follow-up, the patient had complete remission and no significant complications. Talking a little about lymphoma. Lymphoma is a general term that refers to cancer that arises in lymphoid tissue. It can arise from any organ or be disseminated to any organ. Can be classified into Hodgkin's and non-Hodgkin's lymphoma. An orbital lymphoma is a lymphoma which is found in the orbit or orbital adnexa. It is said to be primary if it's arising from the orbital structures themselves, or secondary if it's part of a disseminated disease. They are considered very rare among all types of lymphoma or cancers in general. But to the orbit, they are the most common primary malignancies, especially for patients above the age of 60. As we can see, the range is about 55% of all malignancies in the orbit. Their clinical presentation is usually non-specific. It depends on the location. The vision is usually preserved, as we have seen in our case, as the infiltration for the globe itself or the optic nerve is rare. Why early discovery is very important? Because 30% of all patients will develop systemic disease within 10 years. So early discovery might not be only vision saving, but life saving too. And follow-up should be lifelong if possible. So my take-home messages. First, early discovery might not only be vision saving, but life saving, as we mentioned. The right list of differentials. The right list of differentials would lead us to the right next step. So we have to pay attention to put the right list of differentials. Immunohistochemistry is a very important tool in diagnosis and should not be ignored. The treatment plan must be multidisciplinary. A one doctor management plan, it might not be the best choice for the patient. And the last piece of advice is that the plan of management should be put in count of individuality. Each patient is different and specific. We should not just only follow the protocols, but we should look at the patient's case in a specific way and put a management plan that suits him individually. Those are my references, and thank you for your valuable time. This is my email. I would welcome any questions.
Thank you, Reem Al-Faqih, for a very nice presentation. And now I want to invite Dr. May Abdul Qadir to give her talk. May, you are with us? May? Thank you, Reem. May?
Nice presentation, Dr. Anir.
Hello. Hello, Dr.
Hello.
Fatima.
Yes, May.
Can I start sharing my screen?
Yeah, please.
Yes.
Okay. Good evening, everyone. I'm honored to be invited to share in the Young Ophthalmologist session of this prestigious conference. It's May Abdul Qadir, Assistant Lecturer of Ophthalmology in Cairo University Hospitals. So let's start with our case today. She was a 26 years old female patient who presented to us with 2 brownish masses that were cosmetically annoying her. She also complained of pain and drop of vision for 1 year duration in her left eye. She also gave us a history of trauma during her childhood and a poor vision in this left eye since then, but this drop of vision has increased in the past 1 year. On examination, the right eye was normal and unremarkable examination. The left eye had no perception of light vision. The intraocular pressure was elevated, was 36. The anterior segment examination could not be assessed well as there was a retrocorneal blackish membrane, but there are a picture of the patient showing the 2 masses that annoyed her. Also, the posterior segment examination, of course, wasn't feasible. We made a provisional diagnosis that this is an anterior staphyloma, and we sent the patient to do an ultrasound that came back with a tractional retinal detachment. Also, we performed the UBM, and we found the retrocorneal blackish membrane that may resemble an old hyphema, the anteriorly dislocated lens. Also, there were iridociliary cleft, and that was quite compatible with her history of trauma. But also we found another thing in the UBM. We found 2 masses of medium echogenicity. Here, as we find the sclera adjacent to this mass, it was thinned, but overlying this mass, there was no sclera, and this is only a hypertrophied conjunctiva. That was really suspicious for us, so we decided to perform to send the patient for PET CT scan. That came back confirming our suspicion that there is a metabolically active left eye neoplasm. Since this is a blind, painful eye with high suspicion of malignancy, we decided to do enucleation and pathological examination. Her pathological examination confirmed the presence of ciliary body melanoma with optic nerve margin infiltration. It's worth mentioning here that the optic nerve margin infiltration in cases of uveal melanoma is rare, not as much as we see in cases of retinoblastoma, for example. So to exclude any intracranial spread and to assess the remaining part of the optic nerve, we did MRI brain and orbit, and it was free of any remaining tumor. Our further management, since there is an optic nerve infiltration, we need to do further management. Enucleation wasn't enough. After consulting the ocular oncology service, they confirmed that it's better for the patient to do external beam radiation, and this is the new recommendations, rather than exentration. So the uveal melanoma is the most common primary intraocular malignancy in adults. It represents 3 to 5% of all the body melanomas, with the highest percentage for the choroidal melanoma being 85 to 90%, then the ciliary body melanoma 5 to 8%, and the iris melanoma 3 to 5%. The risk factors include the white race, light-colored iridis, patients with nevus of Utta, patient who has multiple iris nevi, xeroderma pigmentosum, and also a positive family history. Regarding the histopathology, the uveal melanoma arises from melanocytes of the uveal tissue. It's either de novo or on top of a previous nevus. The histopathological types, the original calendar type had 6 classes, but now we tend to classify them into spindle cell melanoma, mixed cell, or epithelioid cell. The epithelioid cell carries the worst prognosis, and the spindle cell better prognosis. Here's the difference between both types. The mixed cell type, as we see, both components, and the spindle cell, where the cells are tightly packed together and there's no indistinct cell boundaries. Regarding its spread, it's well known that they do not spread with lymphatics. It's only local spread, transscleral or to the orbit, or hematogenous spread. The most common site, of course, is the liver, and this is the autopsy of a patient who died from liver metastasis from choroidal melanoma. And as we see, the black patches resembling the primary tumor. Also, there were many cases, case reports. It's rare, but there are case reports talking about that brain metastasis, skin or lung metastasis as well. So the common signs for the ciliary body melanoma include the presence of sentinel vessels, lens manifestations including lenticular astigmatism, subluxation, or localized lens opacity, also extraocular erosion or retinal detachment if there's a posterior extension. After reviewing the literature, we dig more to know about the unusual presentations of the uveal melanoma. We found many case reports talking about that the uveal melanoma may present or manifest as staphyloma, like we see in this case. Also, this is another case who presented to the emergency room with partially eviscerated lobe. She gave history that she has been treated as an anterior staphyloma for 3 months in another hospital. The doctors decided to complete the evisceration, and intraoperative, they found that the uveal tissue is thickened and very adherent to the sclera. That was suspicious for them, so they proceeded to do enucleation, and the pathological examination confirmed the choroidal melanoma. Also, another unusual presentation is the ring melanoma, which present with a refractory glaucoma that's difficult to treat, and it's even difficult to recognize or diagnose unless you do very careful gonioscopy. Although it's a relatively small tumor, but it has a bad prognosis, and the life expectancy is low due to high incidence of distant metastasis. This is another patient, also speaking of the refractory glaucoma, who presented with asymmetrical cupping, field changes, the open angle in gonioscopy. He was diagnosed as primary open angle glaucoma. He started timolol and latanoprost. 9 months later, the patient developed heterochromia, and that was referred to the latanoprost he used. But actually, The pigmentation was suspicious for the doctors. They consulted the ocular oncology, and they took a biopsy that confirmed that there was a diffuse ring iris melanoma with infiltration to the angle that caused the glaucoma. And that gives us the importance of very careful examination of any patient and the picture documentation. I'm not going to talk about the treatment or any further management plans because this is beyond our scope and time, but I'd like to emphasize the importance of UBM in those cases, because most of the ciliary body tumors, the small ones, are difficult to be recognized, and they cannot be seen by slit lamp examination, gonioscopy, or indirect ophthalmoscopy. Also, the UBM helps to detect the tumor extension into the iris and the ciliary body and assess the lateral tumor spread. What can we find in the UBM if there is a ciliary body melanoma? The first important feature is loss of the normal acute shape of the angle. It's either, as we see in the first picture on the left, it's a convex, or it's a linear, as we see in the second picture. Also, we may find tissue with medium echogenicity in the angle. It's important to detect posterior extension in the lens equator or the surface, as we see in the first picture on the left side. And this is another ciliary body melanoma extending to the lens surface. And this is important to decide the management, because if there's an extension, we may not be able to do a local resection. Also, it's important to detect the scleral invasion, as in the second picture. And lastly, the serous retinal detachment if there is a posterior extension. So also, the UBM is important to differentiate if this is a staphyloma or this is an invading melanoma. As we see in the picture on the left side, this is a thinned but intact sclera, and there is no mass. So this represents a staphyloma. But as we see on the right picture, this is our patient who had a thinned sclera adjacent to the mass, but above the mass, there is no sclera, and this is only a hypertrophied conjunctiva. So my take-home message is that ultrasound and UBM are very important in examination of such cases. The UBM provides useful information about tumor morphology and growth patterns. However, the definitive diagnosis is best reached by histopathological examination. Trauma can distort the eye anatomy, but the malignancy also does the same thing. So there is always a place for double pathology. The ciliary choroidal melanoma can present by a staphyloma or mimic it. I'd like to thank the Ocular Oncology Service in Cairo University under the supervision of Professor Dr. Hani Hamza. Thank you for your valuable time.
Thank you, my very nice presentation. Dear panelists, any question to our speaker? Anyhow, our time is over. Thank you very much for everyone sharing with us this session. Thank you for our speakers and for their great and very nice presentation. Thank you very much for everyone.